We're going to continue with the trans theme, but go trans umbilical.
Awesome. Well, thank you very much.
Good morning.
For the invitation. First time here. I love it here. Thank you. Thanks. Appreciate it. Dr. Salas, everybody. Bom dia. So I come from the San Francisco Bay Area. Would love to see you out there. No financial disclosures. I'm going to talk about a procedure that I'm in love with. The Trans Umbilical Breast Augmentation with silicone implants. I do all the approaches, but this is definitely my favorite. This is my staff. I operate out of a fully accredited facility. And this is a non-FDA application. If you would like to come and learn this procedure, I would love to teach it to you. So we have our upcoming workshop in April 24th, 2026. This is through the World Association of Gluteal Surgeons. Multiple advantages to this approach. Dr. Dowden has presented studies, pretty much minimal complications, and this is with saline implants. We published a study. There's only a few, because there's only a few doctors in the world that are doing this. I was the first one in the United States, and similar minimal complications. Pretty much everything is a zero. The tunnel seroma is not even a seroma. It was a collection of fluid. I saw the patient the next day. I pressed on the tunnel, and it went down, and didn't need to aspirate or anything. So no scars anywhere. Really, this is just incredible. We do everything with blunt dissection and hydrodissection using the tumescent anesthesia. Okay, so these are the markings, midline, sternal. So now we're going to do a cone dissector, and we're going to slide it to make our tunnel, and I'm going to go lift the breast so that the pectoralis major muscle lifts, and now we move medially. And now we're going to do the same on the other side, and lift the pectoralis major muscle and go through the inframammary fold, and that's all there is. Thank you. We're going to use this blunt instrument here. It's a hockey stick, and we're going to slide it through the previously made tunnel. And we already did hydrodissection of the pocket using the tumescent anesthesia. So the pocket, the subpectoral pocket, is already made, see, with tumescent anesthesia. We're just finalizing the dimensions. I'm rubbing against the ribs here, and I am detaching the pectoralis major muscle attachments medially and a little bit inferiorly. And with the back of the instrument, I am going laterally. And that's all there is. And now these tunnels, I'm gonna make in the same fashion. This particular patient has some tough fibers there, so you can even hear them. And so this instrument has to be able to slide back and forth without any of these attachments there. So it has to go in back and forth easily, right? And you gotta be careful that you're right in the tunnel and you stay in the subcutaneous plane. So it's a lot better now already. You can see that instrument is moving back and forth easily. And we're gonna do this side. Thank you. Okay, so now we're gonna go ahead and insert the sizers. So these are the test implants, and I use modified sponge forceps to advance the implant into the subpectoral pockets. And I get a 60 cc syringe, and I'm gonna put air into the sizer. You can put saline if you like, but I usually put air, and that's just fine. And so, and we all count out loud. So I'm gonna put my hand at the level of the inframammary fold to make sure that that implant does not inflate under my hand, and it's not inflating under my hand. And so we have 50, and now we have 100. At the count of 100, my assistant puts a line through the paper, and we're gonna go ahead and prompted me to remove the Patino mammary implanter. So I remove it nice and easy, and now we're gonna continue our inflation. Thank you. All right, so we have 100, and that's 150. 250. And this is the left side. The left side is going to go to 300. So I'm going to put my hand here at the level of the inframammary fold. It's 300. And notice if you come from the top, Wendy, you're going to see the almond shape, characteristic of the subpectoral pocket. And these are 300 ml sizer implant. And then we're going to go ahead and show you how we do the silicone implants. So now I'm going to use my non-dominant hand to break this implant down through the tunnel, and it should slide nice and easy. A mistake is to start pulling here because you can break the implant. Now I'm going to have my assistant push on the sizer so the sizer comes out, right? And we want to start pushing Brooke on that sizer, and so the sizer comes out nice and easy. And I'm going to go ahead and remove the sizer and immediately go ahead and place our silicone implants, right? So these are silicone implants, and Brooke is retracting with the Army Navies. And so we do what we do with the killer funnel. Important thing here is to make sure that the valve is down, so the valve is down. And so I'm going to deploy the implant, and Brooke comes out with the Army Navies and give me some space so that they can see how we advance this manually without any trouble at all in a matter of seconds. Thank you. Perfect. Okay, so now we're going to go ahead and, with my non-dominant hand, push that implant back. And the reason why I say my non-dominant hand is, you know, I'm ambidextrous, but hoping that maybe I don't need any help, but I guess I needed some help. But the main thing is not to pull here. And now Brooke is going to go ahead and maybe I can do this by myself so that we don't obstruct the view. So I'm gonna go ahead and usually have my assistant in the back, making sure that pushing and making sure that the implant doesn't ricochet back into the cavity. But basically that's your sizer right there. And what I'm gonna do is I'm gonna go ahead and now go ahead and get ready to put that implant in there, right? The silicone implant that is. And so now we're gonna have Brooke come over, and we're gonna go ahead and place the Army Navies. Usually, I mean, here we're gonna make sure that the Army Navy is in the middle. It's not into the wrong tunnel, okay? That's very important. So now I'm gonna go ahead and put this side, as you have some asymmetry. So this side is gonna receive a 325 mentor implant. The valve is down, and you do what you do with the killer funnel, right? And when I go ahead and deploy that implant, make sure the implant doesn't go into the wrong pocket. You know, it could go there. Sometimes I put my finger there, but it seems like it went into the correct pocket. So I'm gonna go ahead and remove the Patino mammary implanter, and I'm gonna show you how we advance this manually. And this is kind of the problem that happened with the plastic surgeons that were sitting on the FDA committee. They thought that the implants were inserted with instruments, and I guess they didn't approve it, but no reason why the FDA would not approve these, because as you can see, the implants are advanced manually and with a no-touch technique with the killer funnel. Thank you. All right, so what are the advantages of this approach? Well, the most obvious advantage is that there is no scars on your nipples, armpits, or inframammary fold. Typically, these would require a 6 centimeter incision on either side. That would be 12 centimeters total. So this is how big the scar is going to be. I know that you could do it with a smaller incision, perhaps 10 centimeters for total, maybe even 5 centimeters. But compare that, compare that to this incision is 1.5 centimeters. So this is crazy. The second and the important advantage here is the risk of infection. The risk of infection with this approach is 0. And the reason why is because it's a small incision, similar to liposuction. minimal risk of infection. In addition to that, a large implant, especially present against an inframammary or nipple areola complex, is going to cause H ischemia, subsequent necrosis, and infection. The third advantage is the lack of bleeding. The incidence of bleeding with this approach is 0. The reason why is because we are using modified tumescent anesthesia that I modified in 2004, namely 2 ml or 2 milligrams of epinephrine is my dose, and we use 28 milligrams of lidocaine, 2% lidocaine, 28 milligrams per kilo, because we're using general anesthesia as well. Probably the most important advantage is that the combination of these two factors, the lack of bleeding and the lack of infection, translate into a much lower risk of capsular contracture. And this is true with saline implants, which this technique was invented by Dr. Gabriel Johnson in 1989. And he did only subglandular placement. As you can see, we can easily put subpectoral implants, and in my practice, almost 100% of our patients have chosen the subpectoral placement for the last 20-something years, since 2004. So you can put it subpectoral, you can put it subglandular, but Dr. Dowden reported with saline implants the risk of capsular contracture to be 0.2%, as mine is a little lower than that even, and the risk of capsular contracture is less because the main etiology of capsular contracture, as you know, is infection and bleeding. And malposition of the implants, it's almost impossible to place the implants in the wrong pockets. And even the risk of symptomasia with this approach is near 0, or even lateralization of the implants, because as you're doing the tumescent anesthesia, you can see how big the pocket is from the outside, not inside with electrocautery and lighting or anything like that. From the outside, you can see how the pocket has been made. In addition, it avoids sharp instruments and electrocautery into the pockets, which can cause pneumothorax. The risk of pneumothorax with this approach is 0. The risk of intrathoracic or intra-abdominal injury with this approach is 0. So it's an incredible approach. Hydrodissection of the pockets, hydrodissection of the tunnels, and this modified tumescent anesthesia. The pockets are made with hydrodissection and really one blunt instrument, and the insertions are manual. So the risk of rupture during insertion is near 0 with my approach, because I don't use any instruments to advance the implants as you saw. Well, thank you so very much for your attention. This is a technique that is worth implementing and learning. I will be happy to teach you how to do this. We have workshops throughout the year, and this is the way of the future. I think that as a woman, you should not accept scars in your breast, nipples, or inframammary folds. And as a doctor, you should move into the future and offer this to your patients, because it's got much less risk and complications, extremely safe procedure. There is a steep learning curve, but we'll be happy to guide you through it. Thank you.